brief one, narrowing the divide. Bias, because there is some. We help leaders align on what success looks like and how to get there, which means we've been immersed in hundreds of discussions about emerging risks and opportunities and what to do about that. So we maintain a formal force map and a formal thesis, and we refresh that regularly. But today's briefings are inevitably influenced by that bias. So full disclosure, our thesis, after discussions with hundreds of health innovators, is access to care is getting worse. Healthcare costs are going to keep growing, and the gap is going to keep widening. This gets worse, not better. So what? Lots of people think that. Well, but we've really gone deep, and we believe between now and 2030, it gets worse. We also believe there's really only two levers that can be pulled. The first is capacity, starting with you can try to add capacity. BC Health is certainly trying to do that on many, many fronts. But is it actually going to solve this? Burnout is real. Churn rates are high, and training, recruiting, and onboarding healthcare professionals takes a long time, whether it's doctors, registered nurses, coaches, it all takes a long time. Then there's the old, let's become more efficient, which is great. We should do that. But health systems don't even have a mandate to deliver care, and care delivery organizations are already fully focused on trying to be as efficient as they can. So yes, we'll do that, but there's really nothing new here. Now, reduce clinical burden, that's a little different because that's an area where both care delivery organizations and health systems are fully aligned that this has to get addressed because it's a huge driver of physician burnout and churn. And so streamlining processes, automating time wasters, offloading tasks, all of those things are super important and absolutely a focus. And they should be, because if you can reduce burnout, you should help reduce churn, and that effectively increases capacity, which is a major unlock. So yeah, that one's important. But wait, what about AI? I thought that was supposed to solve all this. Well, from a capacity perspective, we believe that it is absolutely going to amplify efforts to reduce clinical and administrative burden. And more importantly, we think it's going to happen across 4 levels. The first is the user experience level. A conversational interface could massively reduce the frustration and wasted time of trying to learn endless workflows and search across endless systems to get the information needed to deliver or support care. And then there's the job layer. So you got the information, but you got to do something with it. So starting with things like generative AI summaries, which can ingest massive amounts of information and generate trusted answers and summaries and be queried in real time, that's going to reduce a lot of wasted time trying to get the right data to deliver care. Then there's AI scribes, which everybody's adopting, and they are going to be helpful because their ability to ingest and make sense of lots of unstructured data is going to help a lot with figuring out how to summarize things and what data to put in which of the systems of record. That's a big deal. Then there's data and interoperability, and this sits under the UX and under the job layer. This is just actually moving data in and out across the different data silos. And already we use RPA across almost all health services to try to reduce the amount of repeat actions. And it works fine, except that it's quite brittle. And so the hope is that AI is going to make it a little more robust and fault tolerant. At the very high level, the most big dream, maybe one day the ability to find patterns and predict outcomes means that AI plays a role in optimizing treatment outcomes, general personalization. That would be amazing. That's long term. And all of this comes with challenges. For starters, what we call net new. Sure, it's compelling to imagine a conversational interface that automates tasks, but, and it's a big but, you can't just flip a switch to start leveraging generative AI. It requires entirely new infrastructure capabilities and training to be able to leverage this and trust it and stay compliant. Our thesis? Healthcare organizations are going to be hitting it out of the park if they manage to put all these pieces in place by 2030. The underlying infrastructure demands scale. This is a health system job, and it has to be an urgent priority. Challenge 2, efficiency, or more to the point, the fact that improving efficiency does not equal access to care. It's not automatic. Most AI-driven efficiency gains actually fall outside of care delivery. You can do all kinds of things before care delivery, like figuring out what data and info is going to be required, figure out where it lives, navigate those systems, get a job ready, summarize it, not to mention things like prior auth and scheduling and dashboards. And of course, there's lots you can do after care, figure out which of the systems need to be updated, extract the information from the scribes, navigate the systems, get them updated. And of course, billing and sending referrals and prescriptions and doing payment adjudication and on and on and on. Many, many jobs, but delivering care, not so many, at least not in the short term. The good news is that the approach to reducing the load on clinician lines up well for the adoption of AI. It used to be that clinicians owned the whole job, and now it's common for the physician to have trusted delegates for some of the jobs. They can actually delegate things to a human they trust. That actually lines up well with the idea of delegating to an AI model or agent that they trust, because the accountability chain still remains intact. The punchline: efficiency efforts will reduce frustration and burnout, and that's great. But the only true measure of access to care is access to care. Challenge 3, capacity. People have lots of health jobs that they need to solve at any given point in time. And to ensure that people have access to care, health systems need to have enough care capacity to solve health job demand. Care capacity units vary by health job, location, and time. And they have a fixed lifespan. They're perishable. They expire if they're not used. So at a first principles level, in a capacity constrained system, allowing capacity to go to waste is not okay. That means that health systems must have visibility into the care capacity units. Otherwise, they can't grow capacity. The other lever is demand. So where health systems can help close the divide between supply and demand by proactively reducing the need for treatment in the first place. Things like health literacy, prevention, clinical grade wellness, they all have an impact on treatment demand. Now remember, healthcare is treatment focused. And sure, some demand might emerge during treatment gaps. But to meaningfully reduce treatment demand, it's critical to act before the need for treatment arises. We talk a lot about this in BC. We've got formal prevention frameworks and success targets, but we spend so little money that it's literally not reported. But wait, what about AI? Thought it was going to solve everything. Well, interestingly, when it comes to reducing treatment demand, has massive potential, arguably bigger than during treatment. For starters, there's just the whole notion of trustworthy information. At a UX level, the ability for people to ask a question and get a trustworthy answer back has a massive opportunity to optimize people's well-being and in the process, reduce the need for treatment. There's a job associated with that, which we'll call the personal health companion. It's a trusted personal advisor, generative AI, that has the potential to become the go-to source for information and answers related to all things health and wellness. If this is provided by the health org and it's trustworthy, it's going to free clinicians from answering questions and vastly increase health literacy, all of which is going to have an impact on reducing demand. And interestingly, there's also a connection down to the data and interoperability level because it impacts triage. When you have models and agents that can find patterns and they have exposure to these conversations and answers over time, your ability to escalate to trained agents, coaches, and clinicians when required is going to have a direct impact on maximizing prevention and driving down demand. Then at the ecosystem level, one would hope that the ability to find patterns and predict outcomes mean that AI will play a central role in reducing the need for treatment in the first place. Let's hope. But there's challenges. For starters, treatment itself. AI efficiency, as we saw, it's going to help in many areas, but the impact on care delivery might be quite limited, at least to start with, and that doesn't actually reduce demand. But the impact that AI could have in reducing demand could be huge, and that would translate directly into improved access for care. Our thesis: Personalized health and wellness companions have the potential to completely reinvent prevention, to become the new digital front door. Trustworthy health and wellness info and answers from your trusted specialist or care provider. Triage, escalation to virtual coaches, telehealth, and so on. Proactive nudging, learning, behavioral change, all of these things taken over the course of a lifetime can be complete game changers. But a personalized health and wellness companion is, by definition, personalized, which means there needs to be visibility into person's knowledge and behavior over time. You can't do that without a patient view. Challenge number 2, prediction. These systems are predictive machines. If we want them to do the work, then we have to let them ingest and summarize massive amounts of clinical and behavioral data before, during, and after care delivery, and surface previously unseen risks and opportunities and predict what's coming. Ultimately, that's going to improve outcomes and reduce the need for treatment, but the contextual data streams needed to do this live outside the healthcare system. And even if you had access to those data streams, most of the AI computation also lives outside of the health system's safe zone, which is why health systems have to invest in the underlying infrastructure and training. See, net new stack. Key takeaways? Well, at a first principles level, 3 things appear to be mission critical. 1, minimizing wasted care capacity is mission critical, has to happen, and it requires a system-wide view of both capacity and demand. And you have to measure access to care directly. Efficiency is not a proxy for access. Whether you use AI or not, the only measure of access to care is access to care. And access to care can only be viewed and measured through a patient lens. That's going to require an attitude shift, but it's the only way we're going to see across the whole journey. For briefing 1, that's it. I thank you for your time.